Welcome, everybody, to SADS Live, episode 170. My name is Andrew Landstrom, and I'm a pediatric cardiologist and genetic scientist from Duke University. It's my pleasure to be hosting SADS Live today, and I'm subbing in for the excellent Dr. Mike Ackerman. And I'm thrilled to be able to take your SADS-related questions. And so if you have any, definitely put them in the chat, and we can start our conversation. Just a few announcements. The weather is cooling down a little bit. I live in North Carolina, and so that's a helpful break from the humidity, and the leaves are changing colors. And November is a wonderful time of year for many reasons. A big one is that it's Family Health History Month. And so if you celebrate Thanksgiving, maybe when you pass the turkey, you can ask each other, hey, what's up with your health these days? And it may seem kind of funny to ask your family about their health, but many of you with SADS conditions might understand that, knowing your family's health is empowering and gives you great ability to kind of look forward into your own life, especially with SADS conditions that can be heritable themselves. And so as you sit down over Thanksgiving, maybe have a conversation. A wonderful thing to consider. SADS has some great ways to get involved with November Family Health History Month, and they'll place a link for this in the chat. In terms of upcoming SADS Lives episodes, next Tuesday, November 25th, SADS Live will be hosted by Dr. Mike Ackerman. And so definitely tune in for that. He is, as you all know, a real world expert and wonderful resource for all of us in the SADS community. And so with that, maybe I'll take your questions. So a question from Bine Sesma. Can you explain the FLNC gene? And Bine, thank you for the question. I hope I got your first name correct. So FLNC is a gene abbreviation for a protein called filamin C. And filamin C has a lot of different roles in the heart cell. It is responsible for sort of the structural way in which the heart works. And so you can imagine how certain kinds of mutations, like if you have a mutation in the gene filamin C, that protein might be disrupted. And that structural role in the heart cell might similarly be disrupted. And so we know that individuals with filamin C can have heart conditions because of that disruption. They can take place at any stage in life. Oftentimes more young adults and kind of mid-age adults who get filamin C heart conditions. And when they do, it can be arrhythmias. It can be heart muscle problems like fibrosis and scar that can develop. And it can be heart muscle squeeze problems that develop over time. Most importantly, filamin C mutations can be passed down, just like most other SADS conditions. And so if you have a filamin C mutation, there's a 50-50 chance that that filamin C mutation gets passed to any biological child, regardless of your biological sex or their biological sex. And so if you have a filamin C mutation, know it can be passed down, and it can come from members of the family too. So if you have a filamin C mutation, like many other SADS heart conditions, it might have come from your biological parents. And so that's a little bit about the filamin C gene. It's something to know about, and certainly a gene to follow up with if you think you have a mutation that might impact your heart. If my QTc calculated with Bazette's formula at a heart rate above 80 comes out around 510 milliseconds, but Friederichia's formula gives around 470, which is more reliable? I love the question. Typically, we talk about Bazette's and Friederichia's correction as a way of calculating what a QT interval does with heart rate. And so the QT interval, just to take a step back, is the time it takes for the heart to electrically reset after it depolarizes. And that depolarizing and resetting is the thing that triggers your heart to beat in a synchronous way. If the heart takes longer to reset electrically, that causes a tracing on the ECG to be prolonged, the QT interval. Now, this changes with heart rate. And so if your heart needs to beat quickly, like if you're running or if you're exercising, um, then that QT needs to shorten. And that QT shortening is normal and healthy. And it's in fact needed because if your heart beats very, very fast, but your QT doesn't shorten, it's sort of like trying to flush your toilet when it's already been flushed. You can't flush it again. And your heart can have a similar problem where it can't actually fire again. You can imagine if you're running from a bear, having your heart not fire when it should can be bad. And then when your heart slows back down again, that QT prolongs. And so a QT interval changes from beat to beat and with heart rate variability. The QT little c is a corrected value of that QT, which, as this question indicates, is a way to kind of normalize for some of that so that if you come into clinic one day and your heart rate is 50 or the other day, next day is 100, your QT may change, but your QTC is corrected by heart rate and is a bit more constant. And so there's lots of different ways to calculate that QTC. We typically use Bizet's. It's the most sort of widely used, but it does kind of fall apart if your heart's really slow or if your heart's really fast. It can give you kind of fuzzy measurements. Fredericia is another way to do this. They're relatively similar, but a slightly different calculation. And so generally for heart rates that are kind of in the normal range, and I would say around 80 beats per minute is certainly in the normal range, Bizet's is typically used. And if Bizet's came out around 510, then that would typically be a QTC that's considered prolonged. Fredericia is at that rate coming out around 470, still a little bit abnormal. Thresholds for what's considered long and borderline long change a little bit and are kind of SADS expert to SADS expert dependent. But generally, I would say if you're over about 480 consistently by Bizet's correction, you're a prolonged QT interval, and 510 would certainly be over that. 470 is a bit more in the borderline range. But I think what's most important to take from this is not sort of what the number is today, but what it is over time. And using a consistent correction is really key to make sure we're always calculating apples to apples, comparing apples to apples, not apples to oranges. I hope that helps. Question from Iwa Bay. Why is the sound of an alarm clock considered a risk factor for long QT syndrome type 2? What exactly happens in that situation, and does a PVC occur and trigger torsade de pointe? That's a wonderful question. I would say it's not really fully understood. There is something about the startle of it. And so it's not necessarily loud sounds in general. So if you go to a rock concert for some reason and there's super loud sounds, or if you're watching a loud movie, that's not really the trigger. So it's the loud sound itself, but maybe that's not the problem, but maybe that loud sound and a startle, a surprise. So if you walk up behind somebody and yell boo, or if you're asleep and the alarm clock goes off and it's really loud. There's some thought that perhaps that does trigger a little bit of extra beating from the heart, and that can trigger the arrhythmia. But I would say that the real mechanism, behind that is still remains to be fully determined. But I would say it is a known risk factor. And for example, this is one of the things that we talk to families about if they have long QT syndrome type 2 or a mutation in gene KCNH2. This is a risk factor. Of course, there are other risk factors, but this is one's kind of specific for long QT syndrome type 2. And so we say, um, try to avoid it if you can. So, rather than having the super loud alarm clock, you've got that really soft alarm clock that starts off soft and slowly builds over time. We talk about trying to warn kids before, like, the fire alarm goes off. If there's a fire drill. Um, the cell phone ringtones are incredibly loud, and I don't know about you, but mine can just startle me too. And so trying to be conscientious about those things is really, really key. And another reason to potentially think about medications, which also lower that risk as well too. You can't always protect yourself from being startled all the time. And so if your SADS expert says, hey, look, your long QT syndrome type 2 could benefit from a medication to lower your risk, oftentimes that risk being lowered is also lowering your risk for this type of event. So something to think about. I love the question. Let's see. We have Shannon from Instagram. I've been seeing that in long QT1, that loud noises are a trigger, or is that just sudden noises or sudden loud sounds or things like that? Well, we sort of just touched upon this. You had a great thought, just like our previous question asker. Um, Long QT syndrome type 2 tends to be the loud sounds. Long QT syndrome type 1 from the gene KCNQ1 tends to have a very different sudden death risk, and that's actually swimming. And so there too, the mechanism of that is not fully understood, but certainly for long QT syndrome type 1, swimming is a known risk factor. And so just something to know about if that pertains to you all. Next question from Erica from Instagram. Can a woman with CPVT still take Nadolol if she wants to be pregnant, or should she change to propranolol? Well, in general, if you are well managed on your beta blocker, when you decide that you want to get pregnant and have a baby, typically that's not the time to start making huge changes. Beta blockers, by and large, Nadolol and propranolol, are safe during pregnancy. What is worrisome is if you stop the beta blocker or make a big change from one to another. That's when you start to worry a little bit about side effects or breakthrough arrhythmias, and that can be challenging at times. And so I would say if you're well controlled on Nadolol, something to ask your SADS expert about is simply continuing it through your pregnancy. We have a message from Courtney at Braylon says hello. How are you, Braylon? Good to see you, Courtney. From Tanya Suggs, I have long QT and I've had 15 cardiac arrests. My goodness. The most recent 12 was back in March. Oh my goodness. Will this cause permanent damage to my heart in any way? Well, Tanya, I'm so sorry to hear you've had a really tough time. One cardiac arrest is really hard. 15 is a huge number, and I'm sorry that you're having these challenges. And it sounds like maybe with all the cardiac arrests um, back in March, you maybe had what we call storm, where there's just lots of cardiac arrests on top of each other. In terms of damage to the heart, anytime there's a cardiac arrest, we do worry about things like that. It doesn't always mean that there will be long-term damage to the heart, but by definition, a cardiac arrest means the heart isn't pumping blood as it should out to the rest of the body. And that rest of the body includes the heart itself. And so if all of you is not getting the blood, then it could be that the heart's not getting blood as well too. So there is that possibility that over time, lots of cardiac arrests might lead to an impact on your heart. And so it's something certainly to talk to your SADS expert about. I also think taking a step back, if you have long QT and are having lots and lots of cardiac arrests, that's just plain worrisome. And so I worry about not only your heart, but the whole person. And so there's always opportunities, I think, to have conversations about how we might be able to lower risk. And generally speaking, for individuals who are having a really hard time, like cardiac arrests, those are great opportunities to talk to your SADS expert about what are additional options, what are their medications, some minimally invasive surgical procedures. What are some things that might be done to decrease that? Because I would worry with that number of cardiac arrests that there could be complications down the road. So certainly talk to your SADS expert about that, and I hope that this is something that you can work with your SADS expert to address, because it does sound worrisome. Mel Bertini asks, what are your thoughts on a SCN10A variant and diagnosis of Brugada syndrome? We actually see this a fair bit in our clinic. So, I mentioned I'm a pediatrician, so I lean kind of pediatric and young adults. And we see this kind of all the time. We see individuals who have had maybe a gene test for something, maybe it's seizures, maybe it's epilepsy. Sometimes with whole exome sequencing, we know the child might have something and we want to sequence all the genes at once. And lo and behold, you end up with something like an SCN10A variant. And there's about a billion different SCN something somethings out there. Um, and oftentimes in the literature, they have been linked with things like Brugada syndrome. And so your question is excellent, Mel. Like, what does all this mean for me? Well, there was a group that was convened, gosh, I think this particular group was convened maybe about 5 or 6 years ago for the first time, or at least that's when the paper describing their work came out. And it's a group called ClinGen. ClinGen. You can actually go online right now. You can Google ClinGen and you can see all about this group for yourself. ClinGen is sort of an organization that brings together um, international groups of experts. And what they do is those expert groups work with individuals who are called biocurators who go through the literature and they pull all of the literature, the papers about a certain gene and a certain disease. And they ask, how good is the evidence that that particular gene and that particular disease are in fact linked? And this group was convened for Brugada syndrome and did this for many, many, many Brugada syndrome genes. SCN10A is one of these genes where you're like, maybe that's Brugada syndrome. Like maybe there are even a couple of papers that link it. But the nice thing about ClinGen is they take a objective approach, right? Meaning because the paper says it is, doesn't always mean it is. And the scientists out there will understand that, you always want to be a skeptic, right? Because somebody can claim something, but claiming something doesn't make it true. And so what the ClinGen biocurators do is they take all this literature and they review it with those panel of experts and they award it points. The better the science, the stronger the science, the more points you get. The more science that accrues over time, the more points you get. And the question becomes, what's the relationship between SCN10A and Brugada syndrome objectively? Well, this group, when they published their results, initially found 18 genes that somebody in the literature had said were responsible for Brugada syndrome. However, after ClinGen objectively evaluated the evidence, 17 out of those 18 genes were found to have no disease association. The only gene that it has a true disease association with Brugada syndrome is another kind of SCN gene. It's the SCN5A gene. So only SCN5A does, all the rest do not. I'll say that again, none of them have evidence of disease. And so I would say that if you're wondering about this particular gene, that certainly you might be able to Google a paper or an abstract that says there might be a relationship. But if you take a step back, if you look at the strength of that relationship, and if you look through a international expert consensus opinion, my sense is it's probably a variant in the gene and it's probably not associated with Brugada syndrome. Lee K, I hope I pronounced that correctly. Lee K from Instagram asks, what could be the reason why my heartbeat had to be max 120 with sports with a beta blocker with long QT syndrome type 2? I think this question might be asking, why is it that my heart rate doesn't go up as high when I participate in sports when I am on a beta blocker, which is certainly something that we would actually expect. And the basic idea here is that beta blockers do lots of things for your heart. Many of them really quite good for things like long QT and SADS conditions. Beta blockers actually help the heart to relax a little bit. They help slow the heart down so it doesn't beat as fast. And it helps to slow the heart down kind of both when we're resting as well as when we exercise. And so when we exercise, like when you're playing sports or running or whatever it is that you do, your heart rate needs to increase so that it can pump blood out to the rest of the body. And it does that through secreting adrenaline into your bloodstream. And that adrenaline finds its way to the heart and causes your heart to beat faster and stronger. And that can be a good thing, except sometimes if you have a SADS related condition and an extra adrenaline surge can cause a misbeat of the heart or an arrhythmia. And so beta blockers literally block the receptor, the beta adrenergic receptor, that prevent adrenaline from binding the receptor. And so if you say, hey, look, when I'm exercising, my heart rate doesn't go as high as it used to, I would say it's probably because that beta blocker is doing its job. It's preventing adrenaline from reaching as much of your beta receptors as possible. And so that might be a good thing. And in fact, when we make sure that people have enough beta blocker to protect their heart, we actually look for that and ask, well, if you're able to get your heart rate up to 200 when we put you on a treadmill, maybe we don't have you on enough beta blocker. And so we really look for that suppression of high heart rates to know that we're heading in the right direction. I hope that helps. Follow-up question from Bine about FLNC. For arrhythmias, this is about FLNC. For arrhythmias, can different beta blockers have a better effect with FLNC? Also, what other genes should be tested with? Thank you. Well, that's a great question. I would say, to my knowledge, I'm not aware of any studies that have looked at individuals with filament C and said, well, let's compare all the beta blockers to see which is the most effective. That's not the case for some forms of SADS conditions. So for example, with things like CPVT and long QT, we know that certain beta blockers just flat out do a better job than other beta blockers. For filament C, I'm not aware of any study that does that. The one thing that I tend to think about, not only in this situation, but in others, is in the sort of space of what's called arrhythmic cardiomyopathy, where you get arrhythmias, but you get heart and muscle disease too, and filament C kind of would fall into that category. I actually look to see if there's evidence of the cardiomyopathy too. So for example, if an individual has, say, filament C or another type of arrhythmic cardiomyopathy gene, and they have arrhythmias, my first question is, well, what does the cardiac MRI look like? What does the echocardiogram look like? If the cardiac MRI and the echocardiogram look normal, that's one thing. It's pure arrhythmias. If there's some evidence that there's a little bit of cardiomyopathic change, and all that means is the heart muscle is changing, or maybe there's a little bit of scar, then I think there are certain beta blockers that are really synergistic. That means you kind of get extra bang for your buck to also help with that remodeling. And so there's a lot of evidence that certain kinds of beta blockers, like beta-1 specific beta blockers, like metoprolol or atenolol, can suppress arrhythmias and can actually help with that remodeling process. There's one beta blocker that I like among them, which is Toprol XL. So it's a once daily beta blocker that is an extended release. The XL stands for extended release. And so with a once daily beta blocker, you can hopefully treat those arrhythmias and maybe slow down some of that cardiomyopathic remodeling. And so that's just sort of one thing that enters my head when we talk about different types of arrhythmic cardiomyopathy and beta blockers. I like the question. A question from Karen Peck. I found out a friend has an RYR2 mutation and has polymorphic tachycardia and has an event monitor. She has 2 kids, ages 3 and 5. Should they get tested? Well, let me speak broadly here because we never want to give sort of very specific health advice. But speaking broadly, if this mutation, this RYR2 mutation, is indeed the cause of the polymorphic tachycardia, and many of you at CPVT will know well that mutations in RYR2 are associated with a specific form of tachycardia called catecholaminergic polymorphic ventricular tachycardia, then yes, the standard of care would be to screen for other individuals in the family who might have that same mutation, even if they seem healthy, even if they seem asymptomatic. And like we talked about earlier, with filament C, RYR2 mutations are carried in families in much the same way. They're autosomal dominant. You only need one copy of the mutation to have to be at risk of developing, in this case, CPVT. And what that means is there's a 50-50 chance that any biological child, regardless of the sex of the parent or the sex of the child, will inherit the mutation. And most RYR2 mutations are we consider to be penetrant, highly penetrant, meaning if you get the mutation, you're more than likely to get evidence of disease. That's not always the case with everybody. Sometimes some mutations don't cause disease, but with many CPVT-related RYR2 mutations, that's often the case. And while you may not see a lot of signs of CPVT in little ones, certainly as they get older, they get more mobile, they start running around, their adrenaline levels go up a little bit. You will start to see more ectopy as the earliest sign of CPVT. And we know that sudden cardiac arrest can happen in CPVT at an early age. Um, and we have a lot of things that we can do to reduce that risk. And so generally speaking, for families with an RYR2 mutation associated with CPVT, we do encourage the family to consider gene testing their kids. If the family says, hey, it's not right for us at this time, then we actually clinically follow the kids as if they're at risk, which means a yearly visit with us. And then if they do test and they're genotype positive, we follow the exact same way, an annual visit with us, unless there's concerns otherwise. Now, the nice thing about the gene test is if the gene test is negative, then unless there's some other worry, the child's not at risk of that CPVT that the parent is. And that can actually be really reassuring. And you don't have to come and see us unless you have some other question or just want to hang out and chat a bit. And so for those families, we just say, get the child tested so that we know who to follow and who doesn't need to be followed. And we, especially for a disease like CPVT, it's something that we always recommend. I like the question. Thank you, Karen. We have a question from Carrie Morawski. My daughter is 18 and has CPVT due to RYR2 and was given a Toradol injection for her migraine in her left arm and a Toradol injection for her migraine on 9/17. Her left arm and left ankle have been swollen since the ER doc said he saw some clots on the ultrasound, but wasn't concerned. Should we be worried? It's been 7 weeks with swollen and pain in the biceps. Well, my goodness, that sounds like a very challenging situation. I'm so sorry to hear about all the complications. You go in for a migraine injection and all of a sudden you end up with swelling. Well, so speaking again generally, this kind of sort of swelling after an injection, as you might indicate, as you might think, is not necessarily associated with CPVT or RYR2. Just because you have a RYR2 mediated SADS condition does not mean you can't have anything else. And so certainly migraines are a part of it, and treatment for that is reasonable. I do think if you're having that kind of swelling, that any individual who's having that swelling and it hasn't gotten away, I'd really like to try to find the answer. One answer might be, are there clots? And maybe that's where the ultrasound is coming from. But if there are no clots, but the swelling persists, then you might want to look at other things. There are other things that can cause sort of swelling, inflammation, and speaking generally, talking to your general physician and talking about what specialists might weigh in would be something that is always welcome for families when they have concerns about things that are kind of hard to pin down, and certainly non-cardiac. I would say that for any CPVT patient who has those kinds of things, certainly don't let the heart be a distraction. And so oftentimes what I've seen is that sometimes patients with CPVT or any SADS related conditions, you're a rare disease. You're a patient with rare disease. And so oftentimes families feel like that takes the center stage when they go see a doctor for other reasons. And knowing that, gosh, this is something that probably is not related to the heart will really hopefully help to kind of move things along. But I'm sorry that she is having trouble, and I hope that you will find the answers soon. This is wonderful. Keep the questions coming. From Linda Coors, I have prolonged QT type 2. I've been an EMT for 30 years. That's wonderful work. Wonderful work, Linda. It wasn't until the last year that I was diagnosed and got my ICD. So I've had loud noises for years, but constant noises seems to be more of an irritant for me. Is this an equal of a trigger? Well, I think it kind of goes back a little bit to what we were saying about the nature of the loud sound. Um, Really, it's that startle. So if it's sort of a loud, continuous sound that doesn't surprise you, that might not be the same risk factor as the loud sound that happens unexpectedly, causes your heart rate to jump and you to be startled, you to feel scared, that adrenaline surge. Um, that might be something completely different. And so, generally, while it's probably impossible to avoid loud sounds overall, what we would recommend is the known things that can cause the loud startles. So, you know, loud cell phone rings, uh, the loud telephone ring, smoke alarms, if it's like a something you can avoid, like a fire drill, those kinds of things. And generally, the loud sounds overall, not so much. Question from Alona Tar, saying a stress as a trigger for long QT1. How do we go about avoiding it? It's just a part of life. I totally agree. Well, I think Alona, a couple of thoughts here. So, for long QT1 in general, the kind of known risk factor tends to be, either swimming or a bunch of exercise. And, with both of these, you're right. Like avoiding these things may not be possible. In fact, we know what happens when people take beta blockers and they sit on a couch and they don't exercise and they don't do the things that they love. And we know that if certainly in kids, if you do that to them, you tell them they can't play, they can't do sports, they can't keep heart healthy, they will get things like obesity, high blood pressure, high cholesterol. That certainly sets you up for challenges in life. So I think with exercise, I think many SADS experts would say like you should totally do the things that you need to do to stay healthy and do the things that you love. Stress aside, you're right. Things are going to happen. For example, we talked about long QT2, right? Loud sounds are going to happen. And so the idea is if you are at risk, that's oftentimes where that medication for prevention can come into play too, because you can't control everything. Certainly for patients with CPVT, that adrenaline surge can trigger arrhythmias, but good luck, never feeling anxious or excited or anything like that ever again. It's simply going to happen. And so that's the role of really medications. That kind of takes us back to that previous question about beta blockers, right? So beta blockers for long QT and CPVT have that really important role of sort of serving as a pharmacologic, a medical inhibitor, so that when the adrenaline surge happens, you've got medication to prevent it from potentially causing trouble with the heart. So I totally agree. Can't avoid stress. You have to stay heart healthy. And that's where talking with your SADS expert about preventing potential risk through things like beta blockers can be helpful so that you can get back to living life. Question from Helen. If I don't have mutations in the 17 types of long QT, and my QTC is usually 450 to 480, and once during home measurements, it was 500, does that mean I have long QT? Well, again, so Helen will have to maybe speak in generalities here, um, but you're right. So you can have long QT that has a mutation in a known gene, and there are some patients with real long QT that never have a mutation in a known gene. And what causes that long QT? We simply don't know. It's a really active area of research. Um, but taking a step back, I would say that like I think the biggest question in my mind when situations like this arise is how sure are you that your QT is prolonged? What I've seen a lot of is families come in with the ECG that they got from the ER when they were there with an abdominal problem, right? They got the ECG, making sure it wasn't anything wrong with the heart. And on that ECG, it says QTC of 481. And then in the little box, it says normal sinus rhythm, prolonged QT interval. And oftentimes when families come in with those ECGs, or we get called about those ECGs, the first question is, who read the ECG? Was it the machine? Was it a physician who just read what the machine read, or was it a SADS expert and did they manually remeasure the QT interval? Um, the machine read for a lot of QT and QTC measurements can be quite inaccurate. I've seen automatic QT measurements in the 500s be measured as normal because of how the machine can be quite inaccurate. And so the first question for a lot of individuals like you is, was it a hand measured QTC by a SADS expert? If the answer is yes and consistently so, then it may very well be that person has long QT, and it may very well be that they're genotype negative, one of those 1 in 4, 1 in 5 individuals with long QT who will have no known mutation. But I've also seen a lot of instances where uh, people were worried because they read the machine read, and that machine read can be inaccurate. Jamie from Instagram. My 10-year-old daughter has CPVT. She has the RYR2 gene mutation. She is a de novo case since neither my husband nor I have the mutation. She's currently on nadolol and flecainide, but stress tests show her condition is not fully under control. Her doctor has recommended a left cardiac sympathetic denervation procedure, LCSD. What's your opinion about LCSD surgery? Uh, I love the question. Yeah, I think speaking, speaking broadly, there are a lot of families who are in this position of having a kid or a young adult with CPVT. There's no doubt about that, with the gene variant. Uh, and there's no doubt about the disease process. And so you know what you're treating. And you run them on a treadmill. And our goal, if you run on the treadmill, is to have nothing, nothing. So that no ectopy, no arrhythmias, nothing, nothing, nothing. And we treat with medications until we suppress that. Now, there are some individuals who, even with sort of big doses of medications, there's still breakthrough arrhythmias. There's also some individuals who just feel crummy on the medications we give them, like high dose beta blockers. For many teenagers, it's not a fun experience. And so they either say, I can't take it, I won't take it, or the arrhythmia says, I'm going to break through anyway. And so we have some individuals where the medications that we're giving are simply not enough. And generally speaking, I think of nadolol and flecainide as being two really good medications for CPVT, often medications that we would start and we would, use them together as a team to treat the children that we see optimally. Now, if that doesn't work, especially in children, oftentimes a left cardiac sympathetic denervation surgery, LCSD, is something to consider. It actually, for us, we tend to consider that a bit more frequently than we do ICDs, especially in young children and school-age children, because we know that ICDs come with a lot of complications for kids and young adults, especially with CPVT. In a good center, left cardiac sympathetic denervation surgery is a minimally invasive procedure. There are some side effects of it which actually let us know that the procedure was successful. Things like maybe the left hand is a little bit dry, or things like that. So there's some things that we look for, and we look for those things as signs that the surgery was successful. But in conjunction with good medical therapy, our CPVT families really find that those three things can help even the most challenging arrhythmias. And so it might be something to consider, with your SADS expert. Well, my goodness, I feel like I've just scratched the surface. We have so many more questions, but maybe what we'll do, since we're almost at the top of the hour, is we'll save all those questions for a next time, maybe even with Mike in a few days. And I'll take the last couple of minutes of our time together just to highlight one individual who many of you in the SADS community might know. But Marcia Baker, the SADS program director, is retiring. And this is her last SADS Live. And she's behind the scenes today, making sure everything runs well, just like she is every time SADS Live meets all of you. And it's just one way that she has tremendously impacted all of the SADS organization. She was one of the first people I met when I first got introduced to SADS. And I think I can speak for the entire SADS community and certainly everybody with SADS when I say that, Marcia, you will be very, very missed. And for those of you who are wondering, Marsha is literally sailing off into the sunset, going to Hawaii. And so she's got a wonderful chapter ahead. With that, Marsha, we will absolutely miss you. Enjoy your retirement on behalf of all of us. And so I hope everybody here has a wonderful weekend. Please stay safe. And we can't wait to join you all again soon on another SADS Live. Thank you all very much.